it's really great talking today because you are you work for a next generation ACO, the successor to the pioneer model ACOs. And I guess I'd be interested in perhaps just you setting the table for those who maybe aren't familiar with the next generation program, and in what way it is different than the MSSP ACO program, the larger program at CMS. Next generation is supposed to be the new model. I think there's more downside risk, but there are also different rules as far as telehealth, admission to nursing homes, and I think some Part B cost sharing. So maybe you could just, in a short fashion, thumbnail what Next Generation is about.
We started out actually in the Medicare Shared Savings Program in 2014 and had a 3-year contract with CMS through 2016, where we were relatively successful in the MSSP program. I think we saved maybe around $76 million over that 3-year period for CMS. And we looked at that when it was time to renew for 2017, and we did a deep assessment of the MSSP opportunities versus next gen. And we really felt like, given the way we had invested in our population health management capabilities and our structure, that it would really behoove us, given the benefits of the next gen program, to make that leap. And it was quite a leap. It took an extensive level of review by SWHR before deciding to proceed. At the end of the day, we felt confident that the integrity of our infrastructure was such that we could be successful in taking full risk. And that's really what the next generation ACO model is to us. It's a full risk model. We currently have about 100,000 lives and in the model, and there's a 15% plus or minus risk corridor in that model. And so, actuarially speaking, the odds of missing by more than 15% on a population that great, particularly when you have the spec coverage that's afforded to you, you can avail yourself of in the next gen model, and then of course our own kind of stop loss coverage that we've secured. The odds of missing by more than that are statistically insignificant. And so it, for all intents and purposes, is a full risk model. And we really felt like, there were benefits associated with the ability, for instance, there's population-based payment programs that allow ACOs and NextGen to kind of, it's still the full CMS network, but you can effectively curate more of a preferred network, if you will, in the next generation ACO. And we have found that to be very advantageous. Allows us to collaborate closely with those in the community that are very like-minded around value-based care and are really committed to looking at things from a total cost of care perspective. And so that has led to a lot of our success. Certainly, on the physician side, we've pulled together a physician network that is committed to value-based care, and they have to commit in a number of meaningful ways, including connecting with us electronically. So when we talk about clinical integration, it is where the EMR, in many cases, we've installed well over 300 EMRs in community practices. And so, we have a central data repository where all that data flows into, so that we can really do deep population-based analytics, which is critical to any population health management infrastructure, so that you can learn from that data and provide that information to the physician community. And then, of course, we also take all the claims data in as well, and we risk stratify that, do predictive modeling based off of that, share all that with our physicians, et cetera. So, so it's a deep level of clinical integration that, all led to us having a level of confidence that, we can take this level of risk, even though it's a significant level of risk on, $1.3 billion, 15%, it's a huge amount of risk. But we felt confident that given the investments we've made and the network that we've amassed, and the incentives that we put in place for that network, that we could be successful. Jim, do you have any other thoughts you'd like to add?
No, Peter, again, I want to thank you for the invite. And I think Danny summed it up very accurately. And just to give you a brief bio is I joined the company just 4 months ago. So Danny is the one that has the expertise with the MSSP program as well as Next Gen. And one of the reasons I joined the organization was because of the success and the things that Danny mentioned, the integrated networks, the population health management, as well as a data-driven, patient-centered and patient-focused process. So, that's one of the reasons I joined, and I think Danny, you summed it up perfectly.
So Danny, when you said curate, that you were able to curate the network, could you elaborate on what you mean by that precisely? And are there some rules in Next Gen that allow that curation, selection perhaps is another word for it, allow you to use that in a way that you couldn't in other ACO programs?
Well, it's a good question. The reason I use the word curate and use it carefully is because we do recognize that Medicare has obviously an extensive network of providers, and whether it's MSSP or a Next Gen, they're all equally eligible to participate in that network. And so, when I say curate, what I'm talking about is we've looked at quality data. We've used all this data that we've gathered to try to discern, who has the best readmission rates from a post acute care network perspective, right? And there are a lot of well-intended providers, of course, but not everybody performs the same way. And so, how many are once discharged are coming back to the ED? And so we look at readmission rates. Rates per thousand on ED readmissions, of course, quality scores, et cetera. And then really it's kind of like picking teams. We want to find those providers who have clearly demonstrated that they are committed to value-based care and caring for patients on a kind of a total cost of care focused basis. And so really that's all I'm referring to there, is our ability then to go and we do contracts with those physicians and of course the post-acute care network, ASCs, et cetera, lab companies. And those are the organizations that, we then communicate to our practices and the entirety of our network, which includes, for instance, discharge planning and working closely with UT Southwestern, and University Hospital, and of course Texas Health Resources, and which is a part of our network, which is one of our big strengths, is we've got 29 facilities that of course are driving a large percentage of the overall spend. And the fact that our clinically integrated network is clinically integrated with our acute care side really enables us to have a lot of success in those care transitions that are occurring within our ecosystem. And so we want to work with providers who are fully bought in and committed to the same level of success. And so really, whether it's primary care all the way up through transplantation, we can handle all of that. And we think a lot of our kind of opportunity has been realized through those coordinated handoffs and coordination across that care continuum. So that's what we mean. I mean, which providers are interested in working with us? For instance, if we're discharging a patient from an acute care stay and they need home health or they need SNF or whatever it is, who do we have confidence in based on the data will provide a great level of quality care to that member or patient, and then keep them from having to be readmitted unnecessarily because we know they've got great care blueprints and they're following those.
Does this mean that you've actually dismissed certain providers from your network because they weren't meeting your goals as far as some of things like ED admissions? I mean, are you a sort of a tough grader and there's some moving out of practices that don't perform and moving practices in that do perform?
Yeah, that's another good question. So we do use data to assess practice patterns, both on a physician network side, et cetera. But I want to be clear, when you say, are you moving patients out of the network? Of course, we can't move patients out of the next generation ACO or CMS's network. That's their network. And so it's purely if we could have a patient or a physician conversation with the patient that, this network of providers are providing a demonstrable level of care that we want for our patients, and so they make recommendations for those. But as you know, the patient or member can go wherever they want within the Medicare network. But I think it's really your follow-on. The second part of that question is around, do we look at data and do we kind of curate our physician network, for instance, based off of those same levels of rigor? And the answer is we do. We look at, on a monthly basis, we provide when all the claims data, all the EMR data and quality that come into our system, we analyze that and we report that out to the physicians on a monthly basis. So all of our physicians know what their quality scores are on all the various quality metrics, and there are many that we're tracking on behalf of the entire network. And that, of course, goes all the way down to the individual physician level. And we can slice and dice that across 8 different kind of business levels. If we want to do that at the individual doctor level, at their group level, at a pod, a region, ACO. So we can slice and dice that a number of different ways. But I think, I want to make sure, and we do that on the financial side as well. But, it is in no way perceived as, because we've been doing this for a long time, or intended to be any kind of a punitive kind of approach at all. We, in fact, structured ourselves in our primary care network in what we call pods. We've got 60 of them within the Dallas-Fort Worth Metroplex, and they average 12 to 15 doctors, primary care physicians within the Southwestern Health Resources clinically integrated network that are dispersed all over the Metroplex, and they're kind of geographically aligned. And that's so that they can meet on a monthly basis. And in pre-COVID, they were meeting face-to-face every month. And what we do in those meetings is, it's a great opportunity for physicians in the same specialty to have really cutting-edge levels of data that we're providing to them. And the opportunity for a cross-pollination is where, we get a huge halo lift in our operations. And so it's really not about, hey, your ER visits per 1,000 are just terrible. How are you going to fix that? It's instead, learning from one another. Wow, I see that you're right at expectation, or you're even below expectation. How are you doing that? And so it's this really healthy process. And so we end up having very few physicians that have to be kind of moved on as a result of that. Over the years, we've certainly moved physicians on in a positive way, right? I mean, but it is a process that happens over a long period of time. And what we have found is, by and large, the vast majority of physicians, are very appreciative to have the information, to have that level of opportunity to work with other physicians. And so very few on a percentage basis or total number basis actually ever end up leaving the organization. If we do, we part friends. There's nothing kind of nasty about it.